Hello and welcome back to Neuroclarity. I am Onori Victor, your host. I am a neurology residency applicant, and today's case is adapted from Cheng and Cheng's comprehensive review of clinical neurology. We have done questions 1 to 17 of chapter 2, and right now we'll be doing 18 and 19. So let's begin. Let's start with today's case. A 31-year-old man presents with dizziness, vertigo, and hoarseness after having chiropractic neck manipulation by an inexperienced practitioner. Now, first things first, I need to say this and make this clear. Please try as much as possible to run away from chiro practitioners, especially those who try to manipulate your neck. A good number of times, whether experienced or inexperienced practitioners, a good number of times their patient land to the neurologist, and these patients have devastating consequences of neck manipulation. Anyway, let's continue. On examination, he has nystagmus, findings of Horner's syndrome on the right side, paralysis of the right palate, decreased sensation to pinprick on the right side of the face and hemibody, and right-sided ataxia. Which of the following is the most likely diagnosis? A. Right medial medullary syndrome. B. Right lateral medullary syndrome. C. Left medial medullary syndrome. D. Left lateral medullary syndrome. And E. Right pontine infarct. Now, let's give ourselves some moments to process this question. And I am pretty sure that you came to the same conclusion with me. The correct answer is B. The right lateral medullary syndrome, also known as the Wallenberg syndrome. Let's have a quick discussion. This patient's symptoms actually point strongly towards a lateral medullary infarct, which is caused by ischemia in the distribution of the right pica, that is, the right posterior inferior cerebellar artery. The history of chiropractic neck manipulation suggests a vertebral artery dissection, which is a well-known cause of pica strokes. Now, let us walk through these findings. Vertigo, nausea, and vomiting points towards a vestibular nuclei involvement. Ipsilateral Horner syndrome points towards disruption of the descending sympathetic tract. Ipsilateral loss of facial prick sensation suggests that the trigeminal nucleus and tract have been affected. Contralateral loss of the body pinprick sensation tells us that the spinothalamic tract has been injured. Dysphagia, hoarseness, palate paralysis all suggest that the nucleus ambiguous, which includes cranial nerve number 9 and 10, have been involved. Right-sided ataxia suggests involvement of the cerebellum and the inferior cerebellar peduncle. Now, some may wonder, you said this is a pica stroke. Why can't it be an ICA stroke? That is, an anterior inferior cerebellar artery stroke. And that's a very good question. Now, to answer that, typically, ICA infarct will cause ipsilateral facial weakness due to cranial nerve number 7 involvement, and also there will be ipsilateral hearing loss because of labyrinth artery involvement. In this case, our patient has normal facial motor function and no mention of hearing loss, making pica occlusion the most likely diagnosis. There is a very strong clinical pair that I would like to add before we conclude this question. Wallenberg syndrome generally presents with a cross pattern where we have ipsilateral facial and cranial nerve deficits and contralateral body sensory deficits. Symptoms like hiccups are often seen and are typical for lateral medullary syndrome. Here's a quick checklist for Wallenberg syndrome. When you hear vertigo, hoarseness, Horner syndrome, cross-sensory loss, and ataxia, think immediately of lateral medullary syndrome and think of pica territory. Now, for our next question, question 19, which of the following options is correct regarding the vascular supply of the thalamus? A. It is primarily provided by the anterior circulation. B. The anterior choroidal artery supplies the ventral posterior medial nucleus. C. The posterior choroidal artery supplies the ventral anterior nucleus. D. The paramedian branches supplies the dorsomedial nucleus, and E, the posterior choroidal artery arises from the posterior communicating artery and supplies the lateral thalamus. So, right now we are diving into the vascular anatomy of the thalamus, and this is something that every neurology trainee should have at the back of their fingertip. First, let us note something. The vascular supply of the thalamus originates mainly from the posterior circulation, and there are four main arteries that you need to know, each supplying specific locations of the thalamus. The first artery is called the tuberothalamic artery, also known as the polar artery, and this arises from the posterior communicating artery. It supplies the anterior portion of the thalamus, especially the ventral anterior nucleus. The second one is called the thalamo-perforating artery or the paramedian artery, and this originates from the P1 segment of the posterior cerebral artery. It vascularizes the medial aspect of the thalamus, focusing on the dorsomedial nucleus. The third is the thalamo-geniculate artery, and this arises from the P2 segment of the posterior cerebral artery. It supplies the lateral thalamus, particularly the ventral lateral group of nuclei. And the last artery is the posterior choroidal artery, which also originates from the P2 segment of the posterior cerebral artery. It supplies the posterior thalamus, including the pulvinar region. Now, it's important for us to clarify something. The anterior choroidal artery, despite its name, does not supply the thalamus. It actually supplies structures like the posterior limb of the internal capsule, the optic tract, and parts of the hippocampus. Quick clinical pair. Thalamic strokes can present very differently depending on the vascular territory that is affected. And knowing these specific arterial territories is crucial for accurate localization and diagnosis. So back to our options. A, it is primarily provided by the anterior circulation, so we say that is false. It is primarily provided by the posterior circulation. B, the anterior choroidal artery supplies the ventral posterior medial nucleus. That is false. We've said that the anterior choroidal artery does not supply the thalamus. C, the posterior choroidal artery supplies the ventral anterior nucleus. That's false. We said the posterior choroidal artery supplies the pulvinar region. Note that posterior choroidal artery P supplies P, the pulvinar region. D, the paramedian branches supply the dorsomedial nucleus. That is true. Remember, the paramedial branches are also called thalamo-perforating branches, and they originate from the P1 segment of the posterior cerebral artery. E, the posterior choroidal artery arises from the posterior communicating artery and supplies the lateral thalamus. That is false. The posterior choroidal artery arises from the posterior cerebral arteries, in particular the P2 segment, not the posterior communicating artery. Let's recap. What artery comes from the posterior communicating artery? That is the tuberothalamic artery, and I'm hoping you're also saying it's also called the polar artery. And the posterior choroidal artery supplies the posterior thalamus, the pulvinar region, not the lateral thalamus. Quick one, what supplies the lateral thalamus? Easy, the thalamo-geniculate artery. So, our answer is D. Thank you for tuning in to Neuroclarity. I am Onowuri Victor, and I will catch you in the next episode as we continue to break down neurology one concept at a time. Stay sharp, stay clear. Bye for now.